So good afternoon, everybody, and great to be here. Very much is coming home for me. I'm a GP. I was a GP for many years in Halton, and also working in Knowsley. I'm now still a practicing GP, and I'm program director at UCLPartners, where we have developed these frameworks. I was the national clinical director for cardiovascular disease prevention for 3 years, and I led development of the national long-term plan for CVD prevention, and I was co-founder of CVD Prevent. So with a huge interest over the years in both quality improvement in primary care and prevention of cardiovascular disease. So UCLPartners is one of the academic health science networks, like the Innovation Agency in London. We've developed these suite of frameworks to support us in primary care in managing long-term conditions in the new world post-COVID. So the frameworks have had huge uptake and interest across the country and have now been adopted into the new national programme called NHS Proactive Care at Home. So all of us will be aware of the challenge. We saw an overnight transformation in primary care as a result of the pandemic, with a shift to almost entirely remote care and reduced face-to-face access for our patients. We know, and many of us are worried now, of course, that the disruption this has led to in routine care in long-term conditions, with the significant risk that brings of deterioration in our patients, exacerbations, that is very likely to drive further waves of demand for care, both in primary care and secondary care in the months ahead. But of course, we all recognise too that because we are having to change so much, this brings a pretty big opportunity to actually transform the way that we deliver care for our patients with long-term conditions, not just restoring business as usual, but trying to do it a lot better. It also gives us an opportunity to use the wider workforce to support remote care and self-management and really drive a step change in support for personalised care. And then finally, by optimising clinical care to allow us to get a real population health impact, preventing cardiovascular and other events at scale. So these were the core principles that we've applied in building these frameworks. These are the conditions that are covered, the 4 cardiovascular conditions and the 2 respiratory conditions. We started with a single condition approach, but are now building multi-morbidity resources to support management of these conditions. And this slide really is at the heart of the approach that we've taken, and shows in the centre there, this is summary form, but it shows in the centre the 4 cardiovascular conditions. Our starting point is to stratify in those conditions, use clinical and other criteria from patient records to stratify and prioritise. Who do we need to see now, and who can we safely phase for several months' time, for example. So after the stratification, going into the top box, this is where the workforce innovation lies. So using health staff such as healthcare assistants, health and wellbeing coaches, nursing assistants, etc., to take on significant elements of the long-term condition care. So first of all, supporting patients with self-management, educating using the great online resources on sites like British Heart Foundation, Diabetes UK, supporting patients to understand their condition, knowing when to seek help, knowing what a flare-up or an exacerbation looks like, knowing how to prevent it, but also specific, explicit support with self-care, teaching them how to measure their blood pressure, how to check their feet if they have diabetes, how to spot red flags, and also signposting to resources for shared decision-making. The second area where these staff can help is around behaviour change interventions, brief interventions to support smoking cessation, for example, physical activity, the stuff that we know is really important in management and self-management of long-term conditions, but frankly, we don't have the time to do well in GP and primary care consultations. So this is a real opportunity to get much better at those core elements of care. And then the bottom box is really just aide memoir. That lists the sort of stuff we will do as clinicians, reviewing the results that the healthcare assistant will have collated, but optimizing therapy, checking comorbidities, looking for complications, etc. And you can see this slide is just a very similar approach for asthma and COPD, but some of the text in the upper and lower boxes is different. But essentially, giving the clinician time to focus on the clinical management, but also using the wider staff to support education, self-management, and behaviour change in patients. So for each of the frameworks, there are 6 components. So we've developed comprehensive search tools for EMIS and System 1 that are free to download from our website. We've developed pathways that are not blueprints, but they're pathways for local adaptation. The pathways that allow us to prioritise our patients. Who do we need to see now? Who can we safely phase to later? Pathways that support remote delivery of care, and also identify which bits of the care can be delivered by these wider staff groups. We've developed a number of scripts and protocols to support these staff in their personalised care, proactive care consultations, so that we know the standard and what they're delivering. And in UCLPartners, we have put on some training and are working with local training hubs to support training for these staff to take on these roles. And I've no doubt that the Innovation Agency, I know, are looking at this sort of approach, same approach locally. For each condition, we've collated a whole bunch of digital and other resources that support remote care and self-care. And finally, in the UCLPartners geography, we are providing project management and implementation support, which I know that Julia and colleagues are doing across the Innovation Agency geography. So as an example, I'm going to show you very briefly part of the hypertension framework, and not to go through the detail, but to see the picture. So you see at the top there, we've the prioritization is mainly based on last blood pressure reading, but we've also introduced ethnicity and age into that prioritization. And when the blood pressure is recorded, patients are in priority groups. The healthcare assistant or health and wellbeing coach or other staff will get the latest reading from the patient at home if they have their own machine to update that. And then you see the green box on the right for the patients who are, their blood pressure is normal and to target. They do not need to see a clinician in the near future, at least about their blood pressure. But what they do need is support with education, self-management and behaviour change. And this can absolutely be provided in a systematic way by these wider staff groupings with the appropriate training, but supporting the education, teaching the blood pressure technique, for example, helping them to understand blood pressure and cardiovascular risk, checking access to medication, advising them when to submit readings, etc. But also picking up things like, do they have a QRIS score above 10% and they're not on a statin, so they can refer to a clinician to review with the patient. But of course, these interventions can be provided to all patients, not just those in the lower risk, lowest priority group. So all of the patients that we as clinicians will see to optimize their therapy and their cardiovascular risk, the healthcare assistant or other staff can provide that same support for education, self-management, behaviour change. And just to outline how this will help with our managing our workload in primary care, that we know that between 50 and 60% of our patients with hypertension will fall into the priority 4 group. So we know immediately we don't need to worry about those patients from a clinical perspective. And then we can see smaller numbers in priority 1 and priority 2 group. So it very much helps us to manage our workload. And this slide is really, again, I won't go through the detail. It's just to illustrate our approach here. Our approach has been very much not to just reiterate the guidance, that what should we do in hypertension or in any of these conditions. We know that and we have access to the guidance. Where we struggle in primary care in the real world is how to do this well in complex 10-minute consultations where patients have multimorbidity. So this slide goes through the issues of, if we want patients to do blood pressure at home, what are the issues and how do we solve them? Advising patients where to access a valid and affordable monitor, supporting patients if they don't want to or cannot get access digitally, teaching the patients by video consultation or group video consultation how to check their blood pressure properly to get valid readings, how to check their pulse to look for atrial fibrillation, etc. So very much to focus on, so how do we do this in the real world? So just a very brief case study to illustrate how some of this comes together. So John, our 56-year-old blood pressure with 2 long-term conditions, not very well controlled. He also smokes. He's at high risk, but not taking a statin. he's got a blood pressure monitor at home, but not very confident in using it. So the healthcare assistant or health wellbeing officer or social prescriber, with the training and the resources, contacts the patient by text and phone and video, helps them to access the resources on the Diabetes UK and British Heart Foundation website to help them understand their condition and knowing where they can get more advice. Shares videos showing how to take your blood pressure, how to measure your blood sugar if you need to do it, how to check your feet and legs daily to look for complications and to know what you're looking at. Sharing the Healthy IO device, showing patients how to use that at home with their smartphone to check for protein in their urine. And if they smoke and are ready to quit, signposting to the One You website where they can access a personal quit plan. And really important at this time, asking about mental health and where indicated, signposting the patient to the Every Mind Matters fantastic set of resources. And then finally, just gathering information together, getting the patient's latest blood pressure and weight, their blood results, their smoking status, their Q-risk score. So that's all available for the clinician. And then the clinician contacts the patient again by phone or video or face-to-face, reviewing their bloods, checking that they're happy with their medication, have they got side effects, checking for complications and comorbidities, and noting that they would benefit from a statin, advising the patient why that's the case, signposting the patient to share decision-making resources, and the patient agrees and says that he'll come back and discuss that at the next meeting. And just to finish off, to signpost some of the resources. So we've developed a lot of resources for patients and healthcare assistants. And that central box there is a protocol where we've now brought together the 4 key cardiovascular conditions. So if a patient has one or more of them, they can have a single consultation with the healthcare assistant or the health and wellbeing officer to support them in education, self-management and behavior change. But we've also developed some slide packs for the clinicians for each of the conditions. This is all stuff we know, of course, but what the slide packs focus on is the how to do and very much bring in multimorbidity. So the hypertension slide packs also bring in cholesterol management. The diabetes slide packs also bring in cholesterol management and blood pressure management, which of course are key. And in the packs, they focus on specific challenging issues. For example, with cholesterol, how do you manage a patient who has got muscle pains? What if their liver function tests are abnormal? If you want to start them on DOACs, how do you do that, etc. So lots of practical advice to support. And then we've collated these digital resources that are available, the links that the healthcare assistant or other staff member can share with the patient and demonstrate. Great resources on DUK, Asthma UK, blood pressure, on BHF websites on how do you do these various things and self-manage at home. And a number of resources to the One You, principally the One You websites to support patients in some of these wider prevention issues. And then there is specific hardware that we refer to, of course, blood pressure monitors, which are the best ones, which are valid, which are affordable. A live core, I know lots of you are used to using across Cheshire and Merseyside. The Healthy IO device I mentioned for checking urine for protein, and the FibriCheck device. If we think a patient might have AF, they can use this at home with their smartphone to get a diagnosis. And then very finally, and UCLPartners and I know Innovation Agency too are focusing very much on, so how do we help to make this happen in primary care? It is not enough to put resources out there, even if they're very good resources. At best, we might get more pockets of good practice and worsen health inequalities. So supporting local primary care networks to take this on with project management and training support, working with the training hubs, etc. So we've generated a lot of resources, as are the Innovation Agency, to support a local implementation. And as I mentioned, the frameworks have now been adopted into this new national programme called NHS Proactive Care at Home, with an ambition that all ICSs will be taking this up over the coming months. We have 4 implementation pilot sites, one of which is Cheshire and Merseyside, and 2 in my patch in North London. But as you can see from the numbers above that, we've had a lot of interest in the frameworks. So the UCLP frameworks are very much there to support us to do things differently by risk stratifying and prioritising our patients, using the wider workforce to optimize remote care and self-care, and also helping us to manage our workload and meet our QOF and other contractual requirements. And through this, in this new world post-COVID, ideally to help us improve outcomes for our patients and to improve population health at scale.